Hello, everyone. Welcome to my Defenses and the European Fertility Society. We are back with Dr. Elias Tsakos. You can see him right here. Hello, Dr. Tsakos. Lovely to have you back. Today, we will talk about endometritis. It's always good to have you, and I know that you will have plenty of things to discuss. This is also a topic that I don't think we focus, like particularly. We mention this, of course, every time, I think, but basically we never did a webinar on this particular topic. So I'm really happy that we are bringing this today. How are you feeling? Ready to educate us on topics?
Wonderful, wonderful.
That's good to hear. So before we start, remember that we will simply start with the presentation that Dr. Tsakos has with him today. We will talk about endometritis, as I've mentioned, and Dr. Tsakos will walk you through all the aspects, diagnosis, how to treat it, and all the symptoms that you can expect as well. And afterwards, as always, there will be time for your questions. So please put those in the chat. All is anonymous, and as you know, we are simply here to help you out as much as possible. So type anything that's on your mind. I'm sure Dr. Tsakos will be happy to help you out. And thank you so much for joining. I do see some people are from England. Hello, David. You've been with us before, so I'm glad that you are back. Thanks so much. And I think that we can go ahead with the presentation. I know you are probably very interested to hear what Dr. Tsakos has to say. And just to let you know, Dr. Tsakos is the medical director of Embryoclinic located in Greece, Thessaloniki. So it's really, really late for him. I already know that he started the day very early, but I'm really happy that you are able to still be here with us today. So let's go ahead. Let's not waste time and start with the presentation. Okay?
Thank you, Caroline, and thank you to the European Fertility Society for this collaboration. It's been going on for many years now, and it's a wonderful opportunity to share with you my experience and also things I know and I don't know about so many topics relating to fertility. Endometritis is not endometriosis, okay? Endometriosis is something else. Actually, I'm very proud to present you a book of endometriosis. This is a Greek edition of a wonderful textbook that I had the honor to and the privilege to bring into Greece. And most people now know what endometriosis is, but most people do not know what endometritis is. It's all Greek. It's an inflammation of the lining of the uterus, of the endometrium. So is it relevant with fertility? And the answer is yes. Do we investigate endometritis? The answer is usually no. Is it relevant? Yes. Does it have to do with implantation or also with miscarriages? Answer is both. So I believe that many of you perhaps have experienced some sort of endometritis, whether you knew about it or not. So I will go straight into the subject of this presentation. So it's an inflammation of the lining of the uterus. That's what it is. It is associated with infertility. So these are the chapters of my talk today. I will try to keep it short and sweet for about 20 minutes, and then hopefully we can get some questions until we complete about 1 hour. So endometritis and infertility, very relevant. Endometritis and the association between IVF outcomes, IVF/ICSI outcomes. How do we diagnose endometritis? What are the treatment options? And what happens afterwards in the outcome of infertility? So quite interesting. So what is it? It's an inflammation of the endometrial lining. Can the endometrial lining be inflamed? Indeed, it can. It can be caused by infection. Those infections could be clinically evident. In other words, the woman may realize or may not that she is suffering of that. And that infection, like any other infected organ, may exert impaired function. And what is the function of the endometrium apart from shedding the lining through the period every month? The main function is fertility. So the dysfunction caused by endometritis could lead to infertility. So this is an overview. How common is it? We don't know. We don't know. I presume it's commoner than we think. And this is simply because we hardly ever investigate for endometritis. And I put myself in that group as well. Because in order to investigate endometritis, we need to do what we usually do not perform, which is either an endometrial biopsy or a hysteroscopy or both. And if we do an endometrial biopsy, we do not specifically request usually, or unless we specifically request to look for endometritis, we may have a biopsy report which is not relevant with endometritis. Most biopsy reports are automatically relevant to conditions like polyps, myomas, and focusing on excluding malignancy, and they don't look for the markers of endometritis. So, in my opinion, it's commoner than we think. Now, this may manifest itself by a failed implantation or by miscarriage. So, we have some percentages here, and we see that they become commoner in women with infertility. Approximately 1 in 5 of women with infertility suffer from endometritis. And usually endometritis causes no symptoms, or it may cause some symptoms that are not severe enough to be reported. So 1 in 3 women who keep failing to get pregnant after IVF may have endometritis. It's very common when women have fibroids, adhesions, or polyps. And why is that? Because those anatomical features, those benign, usually tumors, they bring on the tendency to infection, to inflammation. So perhaps this may be one of the mechanisms through which fibroids and polyps cause infertility. What are the risk factors? So IUDs, polyps and myomas, infections, and deliveries and miscarriages, and also abnormal uterine bleedings. Okay, we've been here. This is a wonderful slide. As always, I'm grateful to Dr. Manos Xidias, our wonderful research fellow, who put this presentation together. Thank you, Manos, if you're listening. So, which pathogens, which microbes are associated with endometritis? Either the ones already in the region, in the vagina, or like Staphylococcus, E. coli, Streptococcus, Enterococcus, Uroplasma, Candida, or sometimes other abnormal organisms like Pseudomonas or Klebsiella that are producing this inflammation effect. Clinical symptoms, the commonest clinical symptom is no symptoms. And then they present with indirect symptoms, indirect issues, problems like infertility, implantation failure, or miscarriage. Right, let's talk about fertility. So what's the mechanism? How do they produce that? It goes without saying that the organisms, if they cause the infection, then this area is an unfriendly area for implantation. There's an indirect mechanism which is related to the immune response to inflammation, which is through all those mechanisms that render the endometrial cavity unfriendly for the implantation. And of course, as a as a result of the inflammation, sometimes we see micropolyps. If we're lucky enough, we may pick those up, small polyps, minute polyps on very advanced ultrasound scan, on the 3D, 4D scans, that in my opinion, all infertility women should undergo. But also it becomes even more evident with hysteroscopy. Here we can see the associations between endometritis and infertility, and it's clearly evident that the rate of infertility is much higher in women with endometritis. And the same applies with recurrent pregnancy loss. So what's the effect of endometritis with in correlation with IVF or ICSI? And it goes without saying, and this has been proven by recent research, that we found that it decreases the chance of a clinical pregnancy rate. It decreases the chance of an ongoing pregnancy rate. And this is the reason why some of us, including my team, we routinely prescribe a short course of antibiotics to, if not all, to most women undergoing IVF ICSI. This is a little bit of a blind procedure, but the theory behind it is that if there is some sort of endometritis, my theory is that there's always mild endometritis. I mean, the likelihood of mild endometritis is pretty big. So I don't hesitate to cover with antibiotics, especially if there's associated procedure like egg collection, for example. So invariably, in all my egg collections and fresh embryo transfers, I would give a short course of antibiotics. Now, on the frozen embryo transfer, I wouldn't. I don't routinely give antibiotics. As I said, this is just empirical, but it's based on the fact that a good proportion of women do have endometritis, which is undiagnosed. And that affects the success of IVF. I mean, we don't like inflammation. I mean, inflammation adversely affects the success of any surgical and of any medical intervention. So IVF is no exemption to that. Right. So observation number one is that the presence of confirmed endometritis has definitely an adverse effect, and it decreases the implantation rate. So if we diagnose that, if we're lucky enough, and if our women are lucky enough to have this diagnosis made by either some suspicion perhaps on the 3D scan, some suspicion on the clinical symptomatology, symptoms, history, on hysteroscopy, or even on Pipelle biopsy that sometimes I do specifically to look for endometritis together with scratching. We try to kill a couple of birds with one stone. So, very simple procedure, Pipelle endometrial biopsy prior to embryo transfer, perhaps 2 to 3 weeks before the embryo transfer. 3 birds with one stone. By doing that, you make sure that the cervix is open and you will have an easy embryo transfer. Secondly, you do the scratching. And thirdly, you take a sample for endometritis. And that's very, very cost effective. And it can be done almost pain-free and at very low cost in the outpatient clinic if we want to avoid a formal hysteroscopy. Okay, and that improves, of course, the ongoing pregnancy rate. And the observation number 2 is that the presence of endometritis definitely reduces the IVF outcome. Much lower chance of implantation. So, perhaps it's not my routine, but perhaps I should just seriously consider that to become my routine, at least a Pipelle biopsy, scratching, and an endometritis checkup prior to the embryo transfer. But definitely, if I didn't do it on the novice, on the virgin patient who was having the first IVF, in my opinion, has to be seriously considered after implantation failure, especially when we're using top quality embryos. So much lower clinical pregnancy rate and implantation rate. And of course, if endometritis is mild, as we can see here, mild endometritis, then probably the effect is not that severe, with no success, with no statistical difference. So it's not just a matter of diagnosing endometritis, it's a matter of quantifying and stratifying the level of endometritis prior to IVF. How do we diagnose that? There's all sorts of different diagnoses, but definitely the most reliable method is the immunohistochemical staining for plasma cells. That's the most reliable method, and we must be looking for that. Most of the histopathology colleagues of ours, most of the biopsy experts, unless they're probed, unless they're alerted to look for endometritis, they would only look for malignancies. So I think we have to have a good laboratory and good collaboration with our laboratory, especially when we're sending samples for endometritis diagnosis. So how do we do that? You can see the Pipelle biopsy, which is very simple and has those amazing advantages. I'm a huge fan of Pipelle biopsies, to be honest, and we do quite a few of them in our clinic. Hysteroscopy, that's the golden standard because we have a visual also of the lining. We may be able to provide with a clinical diagnosis if we see micropolyps or even proper polyps that sometimes may be missed by conventional ultrasound scan. More rarely they're missed by the 3D scan, but this is a gold standard, but it remains a little bit of an intervention with a slightly higher cost and all that. So in my opinion, it has a very, very important place, especially for patients with history of miscarriages and failed IVFs. What are the treatment options? Standard option is antibiotics, doxycycline, 2 weeks. Compliance may be a little bit of an issue here. Second line is metronidazole, ciprofloxacin, and of course, some people suggest the test of cure endometrial biopsy. To be honest, I'm not very keen on that because it increases the intervention and all that. I'm very happy not to test again if I'm dealing with patients with good compliance and so forth, and if I don't have any clinical or ultrasound evidence that hasn't been cured properly. There's been a lot of discussions about the role of probiotics. I'm a big fan of probiotics in general, not just for fertility, but also for well-being, for female and male well-being. I think the gut flora is very important to be healthy, and equally the endometrial flora. And indeed, there's an amazing study that we retrieved in 2024 that showed a trend towards improved pregnancy rates after co-treatment with probiotics and antibiotics. So I think that's to be considered. And in my opinion, if it's not just for fertility reasons, I think generally I like to complement probiotics together with antibiotics. And of course, there's the emerging role of endometrial microbiome, which is a molecular examination and typing of the microorganisms in the endometrium. It provides with reliable information regarding the flora and the constitution of that flora, and could assist in defining prognosis and optimizing the treatment. But of course, research is ongoing. So if we want to kill 4 birds with 1 stone, we do Pipelle, which provides cervical assessment check, or mock transfer as we call it, provides scratching, provides sample for endometritis, plasma cell testing and also provides a sample for endometrial microbiome. I usually keep that for more complex cases, or many of my patients who come from overseas, from abroad, and most of them are very complex. I usually suggest that either by means of a PIPEL or through biopsy. So what's the effect on the outcome? It is positive. I mean, that doesn't go without saying. I mean, we have to prove that. And indeed, there's some amazing meta-analysis, some pooled research data shows that it helps if we treat it. 5 times higher ongoing pregnancy rate and live birth rate. That's pretty good going, and 80% less miscarriage rate. So there is clearly there something that we need to address. So observation number 1 is that the treatment of endometritis has a significant positive effect on IVF outcomes. Here we see the cured endometritis. There's no statistical difference here, which is quite interesting. And the take-home messages are that endometritis is a localized inflammatory response within the uterine cavity caused by organisms, microorganisms. It's a common condition, particularly in women with infertility and multiple failed IVF attempts. So, let's keep it in the back of our head that may be associated with all the history complications of our patients. It directly affects embryo implantation. The diagnosis is ideally done by hysteroscopy, but it could be done by PIPEL. The treatment improves the reproductive outcomes. And the treated endometritis patients have the same odds of success compared to women with healthy endometrium. That's very reassuring, which means that if at any certain point we treat endometritis, we remove the adverse factor from our patients, and we make them equally successful with the patients who didn't have endometritis in the first place. And lastly, it may be quite interesting if we individualize even more the diagnosis of endometritis via molecular techniques. And that would probably be the future of endometritis care. So I think that was the last slide. These are some literature. Please feel free to take some snapshots of that. And this is my wonderful team. I'm very grateful to them. Each one of them has contributed to the amazing success of Embryoclinic. Every day we're in tears. We accept amazing messages from all over the world, from successful patients, many of them very difficult ones. And we're very privileged and honored to be able to treat you guys and learn and exchange our knowledge with you. We learn a lot every day from our patients. We get a lot of amazing feedback and a lot of initiation, if you like, for future diagnostic and therapeutic prospects that we investigate and eventually offer to our patients. Thank you very much for listening, and I'm full of ears for questions.
Thank you so much, Dr. Tsakos, as always. Now we will go for your questions. Now I will go to the next question because, of course, there are plenty of questions. I don't want to keep you waiting. The question from Catherine is the endometritis cycle dependent?
I don't understand the question. The answer is possibly no. Possibly no, because endometritis is a chronic. Usually, it could be acute or chronic. But invariably acute endometritis ends up becoming a chronic. And then you can have acute on chronic. So you can have chronic, and then you may have an acute phase. But no, it's not cycle dependent, in my opinion. And it can be diagnosed at any phase of the cycle. To be honest, we even try to culture. In order to avoid even the PIPEL biopsy, we try to identify plasma cells in the menstrual flow. It hasn't been that successful. We tried then to correlate the findings with the PIPEL findings, and we didn't really come up to any amazing conclusions. So it's not cycle dependent. It has to be in the back of our heads, especially when we're talking about unexplained infertility, especially in cases of additional pathology like polyps or myomas or miscarriages or failed implantations, especially with good embryos.
Okay, thank you so much. Karen has another question. Let me just go straight to that. So can a thin lining be a symptom? Scanty short periods. I've had hysteroscopy, but nothing was found, but they struggled to take a biopsy probably as well. Anything you can advise here?
Well, that's a very difficult question. Answer is yes. But in your case, you know, thin lining equals one thing: endometrial adhesions. There's no other cause of thin lining than that. And endometrial adhesions, which is scar tissue, is caused by the combination of mechanical injury and inflammation. So thin lining, thin endometrium maybe most likely is the effect, the outcome of endometritis that has been caused either by a microorganism or by some sort of surgery or by both. Now, they struggle to take a biopsy. I don't understand that. I don't really understand that because you know, you either take biopsy or not, and it shouldn't be that difficult. That makes me a little bit suspicious of the potential possibility of the presence of Asherman's syndrome. So, you know, if your uterus is completely blocked with adhesions, then we may not be able to easily enter the endometrial cavity. So, I think in your case, you know, you need thorough investigation. I would start with the 3D stroke 4D ultrasound scan, and then by hysteroscopy performed in a surgical theater environment by someone seriously experienced. At the same time, performing ultrasound scan, because that's how we do it when we have to treat Asherman syndrome, so that we know where we are, because sometimes you don't. And also with preparations for a laparoscopy as well, either in case we have a suspicion of perforation, which is one of the risks of proper Asherman syndrome hysteroscopic surgery, or in order to diagnose other conditions. I mean, and always remember endometriosis as well. You know, endometriosis is an inflammation. It can independently cause inflammatory reaction in the region, not necessarily in the endometrium, but around the uterus. So, yeah, that needs a thorough assessment, in my opinion.
And no. I will go to...
Yeah, if I can make a little comment. Sure. Most people, the reaction, the reflex, it happens to me very often, every day. When we get a thin lining, especially our women are already halfway through the preparation for the IVF, they have booked the tickets and the flights to come over and have this special embryo transfer. And most of us are trapped and we don't really know what to do. And the reflex is to increase the estrogens and give them more estrogens. And then if we measure the estrogen level in the blood, the estradiol, this could be in the hundreds. And then the lining is still 5 millimeters. And as you probably know, most of you are very seasoned IVF patients. It's not, we speak with each other, we speak in the conferences, we speak with our patients, and we only mention one characteristic of the endometrial lining, i.e. the thickening. That's one of the 10 characteristics we should be looking at. Others could include the shape, the size, the location, the flow, the contractility, the possibility of plasma cells, and so forth. So I think we have been, and I blame the medical community. Good night, Ileka. I blame myself and the medical community that we haven't communicated properly that, you don't flog a dead horse. If you have adhesions in the endometrium and you give tons of estrogens, plus or minus other goodies like Viagra or whatever, there's no tissue there to react. So unless you have increased that possibility of the tissue growing, either by removing the adhesions or by creating a cavity, or even by PRP of the endometrium, or anything that can provide some healthy receptor to the tons of estrogen you're providing, we're just wasting our time, and we are risking our patients with the complications of high levels of estrogens, like thrombosis and so forth.
All right, thank you. And actually, Karen has some few more details. I think it's worth to have a look at this, okay? Because she mentioned here, where visually good quality embryos don't implant on 5 occasions, 42 plus is the likelihood that this could be age-related only. I've also had twin ectopic pregnancy. And to add more information, they couldn't see any adhesions or anything of concern, had hysteroscopy and NK cell biopsy by 2 different people. Seems strange, no one can biopsy me. Can you do this? Can you? And I contact you. Okay.
Very difficult to comment, but trust me. Yes, it can happen. You can have adhesions, and for some reason they can be missed, or the endometrium can be totally filled with scar tissue that, with appropriate lighting or with no appropriate lighting, can resemble the normal. Now, at 42, for example, I mean, it makes a huge difference if it's your own eggs or not. If it's your own eggs, if they're tested or not with PGTA. So it's very complex. I think it's beyond the scope of this discussion, but I always try to keep it simple in my head and give it very simply to my patients. All you need is a good embryo, and then you need a good uterus and the surroundings. Uterus is not just the endometrium. It's also the myometrium. And it's also the surrounding, which is the peritoneum around the uterus and the tubes. Most IVF doctors now are being trained to believe that, oh, who cares about tubes? We're doing IVF. That's wrong. That's not true. And then you have the environment around you, your blood components, the levels of vitamins, the quality of your blood, the quality of your system, your general health and all that. So what is a good embryo is how long is a piece of string? In my opinion, a good embryo for any woman over the age of 35 is an embryo which is, good quality and PGTA tested. At 42, the chance of abnormal embryo, even if they look normal, is higher than perhaps 60 or 70%. So that's an issue. So what I'm trying to do in my mind first, and also explain to my patients, is that we try to optimize all those factors. So we try to use the highest possible technology, the highest possible knowledge to get hold of good quality, top quality embryos. That's why we use AI in the lab to help us identify morphologically the best quality embryos. We like to perform PGTA with the newest techniques, especially for women. Well, for women over the age of 35, definitely for women over the age of 40, definitely for women with more than 2 or 3 miscarriages or implantation failures. Yeah, and then in terms of the endometrium, plasma cells. I mean, I see one of the questions. I've had a biopsy, came back normal. Yeah, ask them if they specifically looked for plasma cells. 9 out of 10 they don't. Perhaps 9.5 out of 10 they don't. Unless you specifically ask the histopathologist. The histopathologists are trained to see cancer. They're not trained to look for endometritis. So unless you specifically ask them for that, unless you specifically sit down with them and check their protocols and check the thresholds, check what's black and white, and how do they quantify, you're never going to get answers. The problem with medicine is that we only get answers to the questions that we ask, the specific questions. It's like having a blood test. You have to ask them, oh, I want to check my vitamin D, or I want to check my iron level, or I want to check a tumor marker. Unless you ask them, they're not going to do the test. So I think that's the confusion. Thank you.
Right. Thank you, indeed. All right, let me just go to the next question from Catherine. Having polyp and fibroids is a good indication that we should check endometritis?
And not just that. I mean, I'm very passionate about polyps and fibroids. It's not easy. It takes me hours, thinking about my patients with individual patients with polyps and fibroids. Unfortunately, it's not very easy to quantify what is the effect of those, what's the adverse effect on implantation. There's a myth. I mean, I had a relative of mine, I have family in Canada. So she came, first cousin. She came for IVF and she had a massive fibroid and 10 centimeter fibroid. And some amazing doctors there said that, it makes no difference, because it's not in the cavity. I know only too well that that's not true. So I think we have to be very pragmatic. We have to be very experienced. If we, some of us, we were fortunate to be trained in fertility medicine and fertility surgery. This is not the case anymore. In my time, in the 90s, when I was getting trained, it went without saying that you should do laparoscopies and hysteroscopies if you want to be an IVF specialist. Now, this is not a prerequisite. Most of IVF trained doctors now, after perhaps 2005 onwards, they're only trained in IVF. So, if you're a hammer, you only see nails. So it's a very long discussion which fibroids and polyps adversely affect, and at which point and when, after how many failures are we going to allow ourselves before we address a polyp and a fibroid? That's something I ask myself every day. So I'm sorry, I cannot answer specifically because I don't know the size, the shape, the location. And also do not forget malignancy. Don't forget that. I don't want to scare anyone. It's extremely rare because we're talking about young women, majority of you under the age of 50. But a malignancy, in Greece, we treat after 54, still young women. The chance of malignancy is extremely small, but it's not zero. Every year in my practice, we diagnose perhaps 3 or 4 cases of malignancy in women in their 40s who have a fibroid or a polyp. I'm not going to go into detail. And I always thank God for that. Thank God for that diagnosis before they got pregnant. Because if they got pregnant and they got the diagnosis afterwards, that would be a death sentence because the diagnosis would be delayed by minimum of a year and a half. So for you, lady, with the fibroids and the polyps, please feel free to email me if you want a personalized, complimentary opinion. I'm very passionate about that. I would love to give you my opinion and perhaps give you a little bit of helpful information. So I'm just typing the email.
Sure, perfect.
Just a quote, my IVF answers, and I will be delighted to answer. If you like to include some scan pictures, perhaps, if you have any, or even scan reports, that should be, and the short history, your age, your previous attempts, previous history, I would be delighted to help you. In my opinion, generally, I like to map the fibroids. In order to map the fibroids, all you need is a very high resolution ultrasound scan machine, driven by, handled by an expert, an absolute expert in mapping those fibroids, not just in terms of location, but also in terms of vascularity, by doing 3D reconstruction of the uterus, and also by also elastography, because elastography, in my opinion, is giving us a lot of information, especially in order to identify the potentially dangerous fibroids or the adenomyosis fibroids that we confuse for fibroids. And so I think it's not easy. I mean, fibroids are very common. More or less 50% of women in the reproductive age would have one or two or more fibroids, more so in the African races. Most people know that, and we should address that, and we should separately. For the IVF experts who are not trained in fibroid management, who are not trained in fertility surgery, who do not have access to high resolution 3D ultrasound and 4D ultrasound scans, I would suggest they use those experts in a multidisciplinary meeting. So, we don't know everything. And if we don't, I think our patients deserve to invite other specialists to work together towards finding the best solution for our patients.
Brilliant. Thank you so much indeed. All right, let's have a look at the next question. So there are more questions coming, but let's see this one. If you have antibiotics, do you have to wait a certain amount of time before treatment? Can the antibiotics be bad so close to take? I know my partner needed 2 and was told to leave it for 3 months before using sperm.
Well, I think it depends on what we're treating, depends on the severity of the clinical, the laboratory severity, the history and all that. But I believe 3 months is a little bit too long. In my practice, 6 weeks is usually more than enough. During that time also, I ask them to be very careful with sexual intercourse, perhaps use the sheath in order to at least keep them as healthy as possible towards the embryo transfer. Can I take one more question? Because I think
yes, sure, definitely. Definitely, and the question will be here regarding Catherine would like to know, so any diet you can recommend to keep uterus healthy? Would you recommend probiotics at lower dose rather than a treatment dose to supplement to help maintain the health of uterus? If you agree, do I need to know any side effects, negative impact?
Oh, very good question. Thank you, Catherine. I learn the diets from my patients every day. Yes, any antioxidant diet would be very helpful, but you don't need a highly specialized diet. Just standard biological vegetable diet, the sun outdoors, countryside. That's very good. Also, lifestyle diet if you like, and a little bit of exercise, and avoid smoking and alcohol. So that just standard stuff. Now, probiotics on a low dose, absolutely, I agree with you 100%. I was actually suggested this by one of my amazing patients, actually some complementary therapists from the US. And yes, in my practice, I give low dose probiotics to everyone, just like I give them, prenatal vitamins. So 100% for it. Low probiotics won't harm anyone, and apart from fertility benefits, there are some general well-being benefits. I actually take them myself as well.
Perfect. Thank you so much. There are more questions, but we will be finishing for today. However, don't worry, we'll definitely forward all the questions to Dr. Tsakos and his team. And as he mentioned, if you wish to get some more details, you can definitely get in touch with Embryoclinic, and I'm sure the team will be able to also give you some answers as well. All right, so we will be finishing. Dr. Tsakos, before we do, any final comments, any final words you would like to add?
I would like to thank you very much. Thank you, Caroline, personally. We've been together for so many years doing those webinars. Thank you to the Fertility Society, the brainchild of amazing people who had this amazing idea to bring experts from all over the world, but also patients to exchange knowledge. And thank you to our patients, to those people in the audience. I can see so many of them, some of them very, very familiar, some friends also. Thank you. Hi, Dave again. Hi, Fiona, my lovely Fiona. I'm waiting for you. Are you coming in March or April? We're all going to be here. I can see some of my amazing patients. Manos is there, a research fellow. I'm going to have to say goodbye for a few years now because he's continuing his training in England, but I'm sure he will shine. I can see amazing people. Samantha, if you're the ultrasound scan, Samantha from the US,
Perfect.
Big hello. You know, makes me very emotional. Of course, Dr. Filiu, amazing fertility doctor at Embryoclinic, Stephanie is there. So thank you. This is an inspiration. Thank you. Keep going. The science is progressing. We know much more than we knew a year ago, much more than we knew a few years ago. And, you know, keep learning, keep at it. All the vast majority of you is going to make it. I mean, I can very confidently say that. And please feel free to send us anything in terms of questions. You know, my team and I have an amazing team of 35, some of them very experienced doctors, very experienced midwives, coordinators. We take questions from all over the world. If we can, you know, give you a little piece of advice that would help, that's for us a major benefit. So please don't hesitate to send us your questions. And I hope to see you soon with another interesting webinar.
Definitely. Thank you so much indeed, everyone, for joining. I do believe it was useful for you. As Dr. Tsakos mentioned, you know, we will be back with some more events with Dr. Tsakos, but also we will be back next week. There are more events coming up, as you know, so I can only encourage you to go ahead and check them out. There are plenty of events on various topics. Dr. Tsakos, lovely to have you as always. Take care, have a lovely evening, and of course we will see each other quite soon. Have a good night, everyone. Thanks. Take care.
Thank you very much.
Bye.
Bye-bye.